welcome to Infectious Disease 101. I am Dr. Namde Moiteke with the Department of Community and Public Health at Idaho State University. In the first unit of this module, we will be looking at the fundamentals of infectious disease epidemiology. Infectious disease epidemiology is a fundamental part of the whole of epidemiology. In fact, subject of epidemiology originally developed from the study of epidemics of infectious diseases. There is a renaissance in the study of communicable diseases stimulated by changes in the pattern of communicable diseases, the discovery of new infections, and the possibility that some chronic diseases have an infectious origin. The development of vaccines and antibiotics was not followed as predicted by the virtual disappearance of infectious diseases. Its prevention and control needs epidemiological knowledge and experience. Let us begin by looking at some important terminology in the area of infectious diseases. First, we'll be looking at infection. The entry and development or multiplication of an infectious agent in the body of man or animals is what is known as an infection. It also implies that the body responds in some way to defend itself against the invader, either in the form of an immune response or disease. An infection does not always cause illness. There are several levels of infection. It could be a colonization, for example, Staphylococcus aureus, as normal flora on the skin and in the nose and throat of humans. Or it could be a form of subclinical or inapparent infection, such as polio. Or it could be a latent infection, as in the case of herpes simplex virus. It could also manifest as a clinical infection. Contamination is the presence of an infectious agent on the body surface, also or on the clothes, beddings, toys, surgical instruments or dressings, or other inanimate articles or substances, including water, milk, and food. Pollution is distinct from contamination and implies the presence of offensive but not necessarily infectious matter in the environment. Contamination on the body surfaces does not imply a carrier state. Infectious disease is a clinically manifest illness of man or animals resulting from an infection. And a contagious disease is a disease that is transmitted through contact. Examples include scabies, trachoma, sexually transmitted infections, and leprosy. A communicable disease is an illness due to a specific infectious agent or its toxic products capable of being directly or indirectly transmitted from man to man, animal to animal, or from the environment to man or animal. A host is a person or other animal, including birds and arthropods, that affords subsistence or lodgement to an infectious agent under natural as opposed to experimental conditions. An obligate host means the only host. For example, man is measles and typhoid's only host. Hosts in which the parasite attains maturity or passes through its sexual stage are primary or definitive hosts, and those in which the parasite is in the larval or asexual stage are known as secondary or intermediate hosts. A transport host is a carrier in which the organism remains alive but does not undergo development. An opportunistic infection is an infection by an organism that takes advantage of a defect in the host's immunity to infect the host and cause disease. Infection by an organism that is not normally pathogenic but can cause disease if resistance is lowered. Examples include herpes simplex, cytomegalovirus, toxoplasma, mycobacterium tuberculosis, and pneumocystis jirovecii. Opportunistic infections are very common in HIV/AIDS. Surveillance is the continuous scrutiny of the factors that determine the occurrence and distribution of disease and other conditions of ill health. Surveillance is essential for effective control and prevention and includes the collection, analysis, interpretation, and distribution of relevant data for action. The main purpose of surveillance is to detect changes in trend or distribution in order to initiate investigative or control measures. When we say a disease is endemic, it means that there is a constant presence of the disease or an infectious agent within a given geographic area or population group without importation from outside. It may also refer to the usual or expected frequency of the disease within such an area or population group. For instance, common cold is endemic because somebody always has one. When conditions are favorable, an endemic disease may burst into an epidemic, as in the case of hepatitis A or typhoid fever. As new control or preventive measures are applied, the endemic status of a disease may change. An epidemic is the unusual occurrence in a community or region of disease clearly in excess of the expected occurrence. The amount of disease occurring in the past, in the absence of an epidemic, defines the expected frequency. Some use the term outbreak for a small, usually localized epidemic in the interest of minimizing public alarm unless the number of cases is indeed very large. The key words in the definition of an epidemic are in excess of expected occurrence. There is no agreement on what constitutes a significant excess when we talk about epidemics. For example, in the United States, cholera is not normally present in the population. Therefore, even one case of cholera could constitute a potential epidemic in the United States. In a country like India or Bangladesh, cholera is always present in some population subgroups. For cholera to be considered as an epidemic in India, hundreds of cases would have to occur. An arbitrary limit of 2 standard deviations above the endemic frequency is used to define the epidemic threshold for common diseases. A pandemic is an epidemic occurring over a wide geographical area, such as a large section of a country or the entire country, a continent, or the entire world, as we witnessed with COVID-19 pandemic. Zoonosis are infections or infectious diseases transmissible under natural conditions from vertebrate animals to man. For example, rabies, plague, bovine tuberculosis, and anthrax. In recent years, several new zoonoses have emerged, like monkeypox and Lassa fever. When we use the term eradication, we mean the termination of all transmission of infection by extermination of the infectious agent through surveillance and containment. Eradication is an absolute process, an all or none phenomenon restricted to termination of an infection from the entire world. It implies that the infection no longer occurs in human populations. To date, only one infectious disease has been eradicated, and that is smallpox. The term elimination is sometimes used to describe eradication of disease, for example, measles, from a large geographic region or political jurisdiction. With current knowledge, diseases which are amenable to eradication are measles, diphtheria, polio, and guinea worm. What are healthcare associated infections? These are also referred to as nosocomial or hospital infections, and they refer to infections occurring in a patient during the process of care in a hospital or other healthcare facility, which was not present or incubating at the time of admission. It can also affect patients in any type of setting where they receive care and can also appear after discharge. Healthcare associated infections include occupational infections among healthcare staff. It represents the most frequent adverse event during healthcare delivery, and no institution or country can claim to have solved the problem yet. Next, we look at the dynamics of infectious disease transmission. Communicable diseases are transmitted from a reservoir or a source of infection to a susceptible host. The medical model of infectious disease transmission, the chain of infection, is shown here. Basically, there are 3 links in the chain of transmission, namely the reservoir or the source of the infection, and the mode of transmission, and then the susceptible host. Starting point for the occurrence of a communicable disease is the existence of a reservoir or a source of infection. The source of infection is the person, animal, subject, or substance from which an infectious agent passes or is disseminated to the host. A reservoir is any person, other living or non-living things or substances in which an infectious agent lives and multiplies, and on which it depends primarily for survival, and where it reproduces itself in such manner that it can be transmitted to a susceptible host. So mark the distinction between a source of infection and a reservoir. But of course, both of them are always the origin of an infectious agent. A reservoir is the natural habitat in which the organism metabolizes and replicates. The terms reservoir and source of infection are not always synonymous, like we've said. For example, in a hookworm infection, the reservoir is man, but the source of infection is the soil contaminated with infective larvae. In tetanus, the reservoir and source of infection are the same, and that is soil. In typhoid fever, the reservoir of infection may be a person, but the source of infection is the feces or urine of patients, or which contaminates food or water. We'll now look at a human reservoir. By far, the most important source or reservoir of infections for humans are humans themselves. Most of the communicable diseases of which people are affected are contracted from human sources. A human reservoir may be a case or a carrier. A case is a person in a population or study group identified as having the particular disease, health disorder, or condition under investigation. A variety of criteria may be used to identify cases: clinical, biochemical, or laboratory. Broadly, the presence of infection in a host may be clinical, subclinical, or latent. These variations in the manifestations of disease are referred to as the spectrum of disease or the gradient of infection. Clinical illness may be mild or moderate, typical or severe, or fatal, depending upon the gradient of involvement. Epidemiologically, mild cases may be more important sources of infection than severe cases because they are ambulant and spread infection wherever they go, whereas severe cases are usually confined to beds. Subclinical cases, otherwise known as inapparent, covert, missed, or abortive cases, are equally important as sources of infection. Here, the disease agent multiplies in the host but does not manifest itself by signs and symptoms. The organism is shed into the environment in the same way as with clinical cases. Thus, subclinical cases, unbeknown to themselves and others, contribute more than symptomatic patients to the transmission of infection to others. And what is more, they are not captured in any of the statistics. Apart from a few, for example, measles, subclinical infections occur in most infectious diseases. In some diseases, for example, COVID-19, rubella, mumps, polio, hepatitis a great deal of subclinical infections occur. Since subclinical infections occur frequently during a person's lifetime, they are responsible for the immunity shown by adult humans to a variety of disease-producing microbes. Latent infection must be distinguished from subclinical infection. In latent infection, the host does not share the infectious agent which lies dormant within the person without symptoms and often without demonstrable presence in blood, tissues, or bodily secretions. Latent infections occur in herpes simplex, infections due to slow viruses, and some other infections. The role of latent infection in the perpetration of certain infectious agents appears to be great. In epidemiological terminology, a primary case refers to the first case of a communicable disease introduced into the population of interest. The index case is the first case to come to the attention of the public health authorities. It is not always the primary case. Secondary cases are those that developed from contact with the primary case. A suspect case is an individual or a group of individuals who has all of the signs and symptoms of an infectious disease yet has not been diagnosed as having the disease or had the cause of the symptoms connected to the pathogen of interest. Whatever may be the gradient of infection, all infected persons, whether clinical or subclinical, are potential sources of infection because the disease agent is leaving the body through frequent stools, vomiting, coughing, sneezing, or other means, and is potentially available for transfer to a new host. In some diseases, either due to inadequate treatment or immune response, the disease agent is not completely eliminated, leading to what is known as a carrier state. A carrier is an infected person that permanently harbors a specific infectious agent in the absence of discernible clinical disease and serves as a potential source of infection for others. As a rule, carriers are less infectious than cases, but epidemiologically, they are more dangerous than cases because they escape recognition and continuing as they do to live a normal life among the population or community, they readily infect susceptible individuals over a wide area and a longer period of time under favorable conditions. Carrier states are seen in cholera, polio, typhoid fever, and other infectious diseases. Modes of transmission are something we would like to look at. Communicable diseases may be transmitted from the reservoir or source of infection to a susceptible individual in many different ways, depending upon the infectious agent, its portal of entry, and the local ecological conditions. The mode of transmission of infectious diseases may be classified broadly as direct or indirect transmission, each of which has subdivisions. Under direct transmission, we have what is called direct contact transmission. Infection may be transmitted by direct contact from skin to skin, mucosa to mucosa, or mucosa to skin. This implies direct and essentially immediate transfer of infectious agent from the reservoir or source to a susceptible individual without an intermediate agency, for example, by touching, kissing, or sexual intercourse, or continued close contact. Examples include HIV and other sexually transmitted infections, leprosy, leptospirosis, and skin and eye infections. Also under direct transmission, we have spread by droplets. Droplets are aerosolized secretions from the mouth, nose, and throat or other body fluids which are sprayed and projected into the surrounding air while sneezing, coughing, spitting, speaking, or other processes. Droplet particles are usually larger than 5 microns and fall rapidly to the ground. That is, they travel only short distances, usually less than 6 feet, before settling. These droplets, which may contain millions of bacteria and viruses, can be a source of infection to others. When a healthy susceptible person comes within the range of these infected droplets, he or she is likely to inhale some of them and acquire the infection. Diseases transmitted by this means include COVID-19, meningococcal meningitis, common colds, and many other respiratory infections. The potential for droplet spread is increased in conditions of close proximity, overcrowding, and lack of ventilation. Also, the direct transmission is contact with soil. Some infectious diseases are contracted by direct exposure of susceptible tissue to the disease agent in soil, compost, or decaying vegetable matter, in which it normally leads a saprophytic existence. For example, hookworm larvae, tetanus, mycosis, and some others. We also have direct transmission which occurs through inoculation into the skin or mucosa. The disease agent may be inoculated directly into the skin or mucosa, as is the case of rabies, which is transmitted by dog bite, also hepatitis B virus and HIV through contaminated needles and syringes. Again, under direct transmission is transplacental or vertical transmission. Some disease agents can be transmitted from a mother to her unborn child transplacentally. Examples include rubella virus, cytomegalovirus, herpes virus, varicella virus, syphilis, hepatitis B, and Coxsackie. Now we'll move on to the indirect transmission. An essential requirement for indirect transmission is that the infectious agent is capable of surviving outside the human host in the external environment and still retain its pathogenicity and virulence till it finds a new host. This depends upon the characteristics of the agent and the inanimate object and the influence of environmental factors such as temperature and humidity. Indirect transmission can occur via a variety of mechanisms, which we'll look at. The first of these indirect means of transmission is the vehicle-borne transmission, and this implies transmission of the infectious agent through the agency of water, food, body fluids, or other biological products such as tissues and organs. Water and food are the most frequent vehicles of transmission because they are used by everyone. The infectious agents can multiply or develop in the vehicle, for example, Staphylococcus aureus in food, before being transmitted, or be only passively transmitted in the vehicle, as happens with hepatitis A virus in water. Diseases transmitted by water and food include chiefly infections of the alimentary tract, for example, acute diarrheas, typhoid fever, cholera, polio, hepatitis A, food poisoning, and intestinal parasites. Those transmitted by blood include hepatitis B, syphilis, brucellosis, trypanosomiasis, infectious mononucleosis, and cytomegalovirus infection. Organ transplantation may result in the introduction of the disease agent, as happens with cytomegalovirus in association with kidney transplants. The next group of indirect transmission is the vector-borne transmission. A vector is an arthropod or any living agent, which could be a snail, for example, that transports an infectious organism to a susceptible individual. Transmission by a vector may be mechanical or biological. In mechanical transmission, there is no development or multiplication of the infectious organism on or within the vector. However, or unlike the mechanical transmission, in the biological transmission, the infectious organism undergoes replication or development, as happens with malaria parasites and microfilaria in mosquitoes. Airborne transmission is another category of indirect transmission. Droplet nuclei are a type of particles implicated in the spread of airborne infection. They are tiny particles less than 5 microns that represent the evaporated residue of droplets. Unlike droplets themselves, droplet nuclei may remain suspended in air for a significant duration and disseminated by normal air currents to far distances. Diseases spread by droplet nuclei include tuberculosis, influenza, chickenpox, measles, and many respiratory infections. Dust can also facilitate airborne transmission when larger droplets that have fallen down become part of the dust. A variety of infectious agents such as streptococci and other pathogenic bacteria and viruses have been found in the dust of hospital wards and living rooms. Some of them, like tubercle bacilli, may survive in the dust for considerable periods under optimum conditions of temperature and moisture. During sweeping, dusting, and bed making, the dust is released into the air and becomes once again airborne. Dust particles may also be blown from the soil by wind, and this may include fungal spores. Coccidioidomycosis is an example of a disease spread through airborne transmission of fungal spores by dust. Other diseases carried by infected dust include streptococcal and staphylococcal infection, tuberculosis, Q fever, and psittacosis. Airborne dust is primarily inhaled, but may settle on uncovered food and milk. This type of transmission is most common in hospital-acquired infections. The next group of indirect transmission is the fomite-borne transmission. Fomites are inanimate articles or substances other than water or food contaminated by infectious discharges from a patient and capable of harboring and transferring infectious agents to a healthy person. Fomites include soiled clothes, towels, linen, handkerchiefs, cups, spoons, pencils, books, toys, drinking glasses, door handles, taps, lavatory chains, syringes, instruments, and surgical dressings. They play an important role in indirect transmission of the infection. Diseases transmitted by fomites include diphtheria, typhoid fever, bacillary dysentery, hepatitis A, and eye and skin infections. Again, under the indirect transmission, we have the group of diseases spread by unclean hands. Hands are the most common medium by which pathogens are transferred. The transmission takes place both directly, hand as in hand to mouth, and indirectly. Examples include staphylococcal and streptococcal infections, typhoid fever, dysentery, hepatitis A, and intestinal parasites. Unclean hands and fingers imply lack of personal hygiene. Lack of personal hygiene coupled with poor sanitation favor person-to-person transmission of infection, as was seen with COVID-19 pandemic. Now move over to the susceptible host. In discussing concepts related to the susceptible host, we will look at things like incubation period, serial interval, generation time, communicable period, reproduction number, secondary attack rates, and host defenses. The incubation period we'll look at first. An infection becomes apparent only after a certain incubation period, which is the time interval between exposure to that infectious agent and the appearance of the first sign or symptom of the disease in question. During the incubation period, the infectious agent undergoes multiplication in the host. When a sufficient density of the disease agent is built up in the host, the health equilibrium is disturbed and the disease becomes overt. Also of interest to epidemiologists is the median incubation period, which is the time required for 50% of the cases to occur during exposure. Factors which determine the incubation period include the generation time of the particular pathogen, the infective dose, the portal of entry, and the individual susceptibility. As a rule, infectious diseases are not communicable during the incubation period, but there are exceptions. For example, measles, chickenpox, whooping cough, and hepatitis A, which are communicable during the later part of the incubation period. Each infectious agent has a characteristic incubation period, which is usually a range. That is, incubation period varies for different infectious diseases and also from one person to another with the same disease. For example, the time from exposure to symptom onset for COVID-19 is 2 to 14 days. Incubation period could be as short as a few hours, as we see in staphylococcal food poisoning, or as long as weeks to months, as is the case with hepatitis A and B and rabies. And also could be as long as years, as happens in the human immunodeficiency virus, HIV. Epidemiologically, incubation period is of fundamental importance for the following reasons. One, it helps in tracing the source of infection and contacts and gives us an idea of the period of quarantine needed. It also helps us with immunization with immunoglobulins and in the identification of a type of epidemic that we have at hand. It can also be a useful index for prognostication. Incubation period in tracing the source of infection and contacts. In the case of a disease with a short incubation period ranging from a few hours to a few days, it is relatively simple to trace the source of infection and follow the trail of the spread of infection, as in the case of food poisoning, bacillary dysentery, or typhoid fever. The position is quite different with diseases whose incubation period is longer. So many things will have happened and such varied contacts taking place that the cause-effect relationship becomes diluted. There will be a whole gamut of possible causes from among which we have to single out the main cause. Only once the source of infection is traced will it be possible to institute appropriate control measures. Now, as regards determining the period of quarantine, incubation period is useful for determining the period of quarantine which may be advised. This period is usually equal to the maximum incubation period of that particular disease. As regards immunization, prophylactically, a knowledge of incubation period helps us to prevent clinical illness by human immunoglobulins and antisera. In the area of identification of type of epidemic, in a point source epidemic, all the cases occur within one incubation period of the disease. In a propagated epidemic, cases occur later than the known length of the incubation period. For prognosis, incubation period can also be used in estimating the prognosis of a particular case of a disease. In some diseases, for example, tetanus and rabies, the shorter the incubation period, the worse the prognosis for that case. Another concept to look at is serial interval. In many instances of an outbreak, we seldom know precisely the incubation period of the disease. But we know that when an outbreak occurs, say in a family, which is the smallest group, and also a close group, there is an initial primary case. The primary case is followed by 2 or 3 secondary cases within a short time. The time interval between the onset of the primary case and the secondary case is what is known as the serial interval. By collecting information about a whole series of such onsets and getting a distribution of secondary cases from which we can estimate the incubation period. By collecting information about a whole series of such onsets, we get a distribution of secondary cases from which we can estimate the incubation period of the disease. Generation time is the interval of time between receipt of infection by a host and the maximum infectivity or communicability by that host. In general, generation time is roughly equal to the incubation period. However, these two terms are not the same. The time of maximum communicability may precede or follow the incubation period. For example, in mumps, communicability appears to reach its peak about 48 hours before the onset of swelling of the salivary glands. Period of communicability. The communicable period is the time during which an infectious agent may be transferred directly or indirectly from an infected person to another person, from an infected animal to man, or from an infected person to an animal, including arthropods. Communicability varies in different diseases. Some diseases are more communicable during incubation period than during actual illness. Communicability of some diseases can be reduced by early diagnosis and treatment. An important measure of communicability is the secondary attack rate. Now we'll look at reproduction number, which is the average number of secondary infections caused by the first infectious person in a community of totally susceptible people. It is expressed by the mathematical term R naught. It describes how contagious an infectious disease is. Secondary attack rate is the number of exposed persons who develop the disease within the range of the incubation period following exposure to the primary case. It is given by the formula number of exposed persons developing the disease within the range of incubation period divided by the total number of exposed or susceptible contacts multiplied by 100. The denominator consists of all persons who are exposed to the case. More specifically, the denominator may be restricted only to susceptible contacts if means are available to distinguish the susceptible persons from the immune. The primary case is excluded from both the numerator and the denominator. Secondary attack rate was initially developed to measure the spread of an infection within a family, household, or any closed aggregate of persons who have had contact with a case of disease. It is also used in determining whether a disease of unknown etiology is communicable or not, and in evaluating the effectiveness of control measures such as isolation and immunization. Secondary attack rate is limited in its application to infectious diseases in which the primary case is effective for only a short period of time, measured in days, for example, measles and chickenpox. When the primary case is infective over a long period, as with tuberculosis, duration of exposure is an important factor in determining the extent of spread. It is indicated by the formula number of contacts developing tuberculosis divided by number of person weeks or months or years of exposure multiplied by 100. Another limitation of secondary attack rate is identifying susceptibles. It is feasible only in diseases such as measles and chickenpox, where history can be used as a basis for identification. But in many others, susceptibles cannot be readily identified, as with influenza. In such cases, secondary attack rate is based on all exposed family members and still remains a useful tool. Where there are numerous subclinical cases, secondary attack rate has a limited usefulness because further spread cannot be measured without laboratory investigations. We look at host defenses. Host defenses against infection are at once local and systemic, non-specific and specific, and humoral, that is antibodies, and cellular. It is difficult to identify any infectious agent that fails to stimulate multiple host defense mechanisms. The concept of overlapping host defenses is crucial to our understanding of susceptibility to infection. This overlap underlies the reasonable measure of good health in the face of an apparently significant host immune defect. There is a phase of passive immunity transmitted to babies from their mothers across the placenta. Maternal antibodies transmitted to an infant are gradually lost over a period of 6 months. Thus, a large proportion of infants remain free from potent infection up to 3 months or even longer. There is a good evidence that this protective biological shield is due to the presence of high levels of immunoglobulins known as IgM and especially IgG in the cord blood and plasma of infants born of immune mothers. It has been postulated that some other factors like breast milk and presence of fetal hemoglobin are also responsible for the transient protection that infants have. We now look at the category of defense, host defenses known as specific defenses. Specific defenses come into play once microorganisms have breached local defense mechanisms. By virtue of these defenses, the host is able to recognize, destroy, and eliminate antigenic materials like bacteria, viruses, proteins, which are foreign to the body. A person is said to be immune when they possess specific protective antibodies or cellular immunity as a result of previous infection or vaccination, or is so conditioned by such previous experience as to respond adequately to prevent infection and or clinical illness following exposure to a specific infectious agent. The specific defenses may be discussed for convenience under the following headings. It could be active immunity, under which we have humoral immunity, cellular immunity, or a combination of these. And it could be passive immunity, which has normal human immunoglobulin, specific human immunoglobulin, or animal antitoxins or antisera given to the individual. Active immunity is immunity which an individual develops as a result of infection or by specific vaccination and is usually associated with presence of antibodies or cells having a specific action on the microorganism or its toxins. In other words, active immunity depends upon the humoral and cellular responses of the host. The immunity produced in response is specific for a particular disease. That is, the individual, in most cases, is immune to further infection with the same organism or antigenically related organisms for varying periods depending upon the particular disease. Active immunity may be acquired in three ways. The first is following clinical infection, as happened with chickenpox, rubella, and measles. The second is following subclinical or inapparent infection, as we see in polio and diphtheria. And thirdly, following vaccination with an antigen, which may be a killed vaccine or a live attenuated vaccine or a toxoid. Passive immunity entails the transfer of antibodies produced in one body from a human or animal to another to confer protection against disease. In other words, the body does not produce its own antibodies. but depends upon ready-made antibodies from another person. Passive immunity may be achieved by first administration of an antibody containing preparation, what known as immune globulin or antiserum, or by transfer of maternal antibodies across the placenta. Human milk also contains protective antibodies, or thirdly, by transfer of lymphocytes to induce passive cellular immunity. Passive immunity differs from active immunity in the following respects. Immunity is rapidly established. Immunity produced is only temporary, lasting from days to months till the antibody is eliminated from the body. And also, there is no education of the reticular endothelial system. So, passive immunization is useful for individuals who cannot form antibodies or for the normal host who takes time to develop antibodies following active immunization. Let's now look at the concept of herd immunity. Herd immunity or community immunity describes a type of immunity that occurs when the vaccination of a critical proportion of the population or herd provides protection to unvaccinated individuals in that community. Herd immunity theory proposes that in diseases passed from individual to individual, it is difficult to maintain a chain of infection when large numbers of a population are already immune. The higher the number of immune individuals, the lower the likelihood that a susceptible person will come in contact with an infectious agent. Herd immunity provides a immunological barrier to the spread of disease in the human herd. When an infectious agent is introduced into a virgin population with a very low or no immunity, the attack and case fatality rates tend to be very high, involving practically all susceptible individuals. For example, this happened in a very severe measles epidemic in the Faroe Islands in 1854, where the population had no previous experience of measles. The epidemic wave declined with a build-up of herd immunity following natural infection. Elements which contribute to herd immunity are the occurrence of clinical and subclinical infection in the herd, immunization of that herd, and the herd structure. Herd structure is never constant. It is important, it is subject to variation because of new births, deaths, and population mobility. Ongoing immunization program keeps up the herd immunity at a very high level. The herd structure includes not only the hosts, the population of the hosts belonging to this herd species, but also the presence and distribution of alternative animal hosts and possible insect vectors, as well as those environmental and social factors that favor or inhibit spread of infection from host to host. The herd structure thus plays a decisive role in the immunity status of that herd. If the herd immunity is sufficiently high, the occurrence of an epidemic is regarded as highly unlikely. If that high level of immunity is maintained and stepped up by an ongoing immunization program to the point where the susceptible persons are reduced to a small proportion of the population, it may lead, but not necessarily, to elimination of the disease in due course. This has been achieved in such diseases as diphtheria and poliomyelitis. In the case of smallpox, however, it may be mentioned that it was not herd immunity, important as it was, that played a critical role in its eradication, but elimination of the source of the infection by surveillance and containment measures. With the abolition of the vaccination against smallpox, the herd immunity in the case of smallpox will naturally tend to decline with the passage of time. In the case of certain infectious diseases which are not transmitted from person to person, like tetanus, herd immunity does not protect the individual. Studies have shown that it is neither possible nor necessary to achieve 100% vaccination in a population to halt an epidemic or control disease, as for example, eradication of smallpox. Just how much less than 100% is required is a crucial question, for which no definite answer can be given. For measles, an estimated 95% of a population needs to be vaccinated to achieve herd immunity. Some studies have stated 90% for COVID-19. Let's now look at the prevention and control of infectious diseases. Every disease has certain weak points amenable to intervention. The basic approach in controlling infectious disease is to identify these weak points and break the weakest link in the chain of transmission. This requires sound epidemiological knowledge of the disease, that is, its magnitude, distribution in time, place on person, multifactorial causation, source of infection, and dynamics of transmission. Frequently, it may be necessary to institute more than one method of control simultaneously. The choice of methods will depend upon factors such as availability of proper tools and techniques, relative cost effectiveness, efficiency, and acceptability. Although effective control of a disease requires knowledge of its multifactorial causation, removal or elimination of a single known essential link or the weakest link may be sufficient to control an infectious disease, even if complete knowledge about the etiology of the disease in question is lacking. The classic example is that of John Snow controlling the cholera epidemic in London by removing the handle of the incriminated water pump. Disease control involves all the measures designed to prevent or reduce as much as possible the incidence, prevalence, and consequences of that infectious disease. This includes community participation, political support, and intersectoral coordination. Control measures should not be delayed because of incomplete or lack of accurate knowledge of the etiologic agent. Broadly, measures should target these areas pending results of epidemiologic investigation, the reservoir or source of infection, the routes of transmission, and the susceptible hosts, all of which constitute the chain of transmission. So the activities of disease prevention and control require community participation and involvement, political support, and intersectoral coordination, as we have said. Now we look at controlling the reservoir, which is the first link in the chain of transmission. If the first link in the chain of transmission, which is deemed to be the weakest link, logically the most desirable control measure will be to eliminate the reservoir of source or source of infection if that is possible. Elimination of the reservoir may be pretty easy with an animal reservoir as with bovine tuberculosis and brucellosis, but it is not possible in humans in whom the general measures of reservoir control will be either early diagnosis, disease notification, isolation, treatment of cases, quarantine, surveillance, and disinfection, all directed to reduce the quantity of the agent available for dissemination. Early diagnosis. The first step in the control of a communicable disease is its rapid identification. It is the cornerstone on which the edifice of disease control is built. It has been aptly said that prompt detection of cases and carriers and their treatment is like stamping out the spark rather than calling the fire brigade to put out the fire caused by the spark. Frequently, laboratory procedures may be required to confirm the diagnosis. Early diagnosis is needed for the treatment of patients, for epidemiological investigations, for example, tracking the source of the infection from the known or index case to the unknown or the primary source of infection. It's also needed to study the time, place, and person distribution, and also for the institution of prevention and control measures. Next, we look at disease notification, or what is known as reporting. Once an infectious agent has been detected or even suspected, it should be reported to the local health authority, whose responsibility it is to put into operation control measures, including the provision of medical care to patients, perhaps in a hospital. Certain diseases are statutorily notifiable. Disease to be notified vary from country to country, and even within the same country, it varies. Usually, diseases which are considered to be serious menaces to public health are included in the list of reportable diseases. Notification is an important source of epidemiological information. It enables early detection of disease outbreaks, which permits immediate action to be taken by the health authority to control their spread. Notification of infectious diseases is often made by the healthcare provider, but anyone, including the layperson, for example, religious, political, or administrative leaders, teachers, and others, can report even on suspicion. In all cases, the diagnosis is verified by the local health authority. Isolation is next we'll look at. Isolation is the oldest communicable disease control measure. It entails instituting a barrier or separation for the period of communicability of infected persons or animals from others in such places and under such conditions as to prevent or limit direct or indirect transmission of the infectious agent from those infected to those who are susceptible or who may spread the agent to others. In general, infections from human or animal sources can be controlled by physical isolation of the case or carrier, and if necessary, treatment until free from infection, provided cases and carriers can be easily identified and carrier rates are low. The purpose of isolation is to protect the community by preventing transfer of infection from the reservoir to possible susceptible hosts. The type of isolation varies with the mode of spread and severity of the disease. Isolation in hospitals are on different levels depending on how the disease spreads. You have contact isolation, droplet isolation, or airborne isolation. Contact isolation usually requires medical staff and visitors to wear gloves and gowns when entering the patient's room, as we have with norovirus infection. Droplet isolation is used when a patient has an infectious disease such as a respiratory infection that may be spread through sneezing, coughing, or talking. Droplet precautions such as surgical masks, goggles, or face shields help prevent contact with nasal or lung secretions containing the infectious agent. Influenza, pertussis, and mumps are examples of infections that require this kind of isolation. The strictest level of isolation is airborne isolation, needed when pathogens can float in the air. In some cases, airborne agents such as viruses can travel into hallways or other rooms, infecting other patients, staff, or visitors. Patients under airborne isolation are typically placed in special isolation rooms called negative air pressure rooms, where the air is removed through a specialized filter system and not allowed to flow into other spaces. A closed door is typically required for airborne isolation. In addition to personal protective equipment used under standard precautions such as gloves, safety glasses, gowns, aprons, and shoe covers, medical staff generally wear specialized respirator masks when they enter airborne isolation rooms. Visitors are not often limited during airborne isolation. Airborne isolation is used for chickenpox, measles, and tuberculosis, as well as COVID-19. For each patient, the relative risks to the patient and to others should be assessed and the appropriate type of isolation determined. Hospital isolation, wherever possible, is better than home isolation. Isolation is particularly difficult in rural areas. In some situations, as with cholera outbreaks, the entire village or rural community may have to be isolated. Isolation may also be achieved in some diseases by what is known as ring vaccination, which is like creating a zone of immune contacts around the case to prevent further transmission. Ring vaccination was used worldwide in the 1960s and 70s to eradicate smallpox. The duration of isolation is determined by the duration of communicability of the disease and the effect of chemotherapy on infectivity. Isolation has a distinctive value in the control of some infectious diseases, such as diphtheria, cholera, streptococcal respiratory diseases, the pneumonic plague, and others. In some diseases where there is a large component of subclinical infection and carrier states, as in polio, hepatitis A, and typhoid fever, even the most rigid isolation will not prevent the spread of the disease. It's also futile to impose isolation if the disease is highly infectious before it is diagnosed, as in the case of mumps. Isolation has failed in the control of diseases such as leprosy and tuberculosis. In the control of these diseases, the concept of physical isolation has been replaced by chemical isolation, that is, rapid treatment of cases in their own homes and rendering them non infectious as quickly as possible. Lastly, cases are usually reported after the disease has spread widely. Taking all these limitations into consideration, it may be stated that isolation, which is a barrier approach to the prevention and control of infectious diseases, is not as successful as one would imagine and may give rise to a false sense of security. In modern day disease control, isolation is more judiciously applied and in most cases replaced by surveillance because of improvements in epidemiological and disease control techniques. Today, isolation is recommended only when the risk of transmission of the infection is exceptionally serious. We move over to treatment as another means of breaking the chain of transmission as regards the reservoir. Many communicable diseases have been tamed by effective treatments. The object of treatment is to kill the infectious agent when it is still in the reservoir, that is, before it is disseminated. Treatment reduces the communicability of disease, cuts short the duration of illness, and prevents development of secondary cases. In some diseases, such as syphilis, tuberculosis, and leprosy, early diagnosis and treatment is of primary importance in interrupting transmission. Disease should also Treatment should also be extended to carriers. Treatment can take the form of individual treatment or mass treatment. In the latter category, all the people in the community are administered the drugs whether they have the disease or not. And we use this in cases in diseases such as trachoma. If the treatment is inadequate or inappropriate, it may induce drug resistance in infectious agents and may frustrate attempts to control the disease by chemotherapy. It is well to remember that no disease has ever been conquered through attempting to treat every affected individual. Next, we look at quarantine. While isolation has to do with persons who have already come down with disease, quarantine applies to people who have been exposed but do not have the signs and symptoms of the disease yet. It is the limitation of freedom of movement of such wild persons or domestic animals exposed to a communicable disease for the usual longest incubation period of the disease in such manner as to prevent effective contact with those not so exposed. Quarantine measures are also applied by health authorities to ships, aircraft, trains, road vehicles, and other means of transportation or containers to prevent the spread of disease, reservoirs of disease, or vectors of transmission. In contrast to isolation, quarantine applies to restrictions on the healthy close contacts of an infected person to see if they become sick. Quarantine, which was once a popular method of disease control, has declined in popularity. However, it resurfaced with onset of the COVID-19 pandemic and has been used a lot. Now, the next point in the chain of transmission is the route of transmission. So we can also interrupt the chain of transmission, the route of transmission. A major aspect of communicable disease control relates to breaking the chain of transmission. This may mean changing some components of the environment to prevent infectious agents from a case or carrier from entering the body of a susceptible person. For example, water can be a medium of transmission of many diseases such as typhoid, dysentery, hepatitis A, cholera, and gastroenteritis. Water treatment will eliminate these diseases. Depending upon the level of pollution, this may vary from simple chlorination to simple treatment. However, control of the source of infection, of contamination, is an important long-term measure. Foodborne disease is particularly prevalent in areas having low standards of sanitation. Clean practices such as hand washing, adequate cooking, prompt refrigeration of prepared foods, and withdrawal of contaminated food will prevent most foodborne illnesses. When the disease is vector-borne, control measures should be directed primarily at the vector and its breeding places. Vector control also includes control of cattle, pets, and other animals to minimize spread of infection among them and from them to man. On the other hand, transmission of infection by droplets or droplet nuclei are not usually controlled effectively by attempting to interrupt their mode of spread. Reliance is placed on early diagnosis and treatment of patients, personal hygiene, and proper handling of secretions and excretions. The last point in the chain of transmission is its susceptible host. The third link in the chain of transmission is the susceptible host or people at risk. They may be protected by one or more of the following strategies: active immunization, passive immunization, combined active and passive immunization, chemoprophylaxis, or non-specific measures. Active immunization is one effective way of controlling the spread of infection. That means strengthening the host defenses. Under certain circumstances, this may be accomplished by active immunization using vaccines, which is one of the most powerful and cost-effective weapons of modern medicine. There are some infectious diseases whose control is solely based on vaccination. Examples are tetanus, diphtheria, and measles. Vaccination against these diseases is given as a routine during infancy and childhood with periodic boosters to maintain adequate level of immunity. Then there are immunizations against certain diseases which are offered to high risk groups or restricted to definite geographic areas where the disease is endemic or a public health problem, as with the case of yellow fever. Unfortunately, we do not have vaccines for every infectious disease. Diseases for which improved or less costly vaccines are needed include tuberculosis, pertussis, hepatitis B, rabies, etc. Vaccination is a mass means of protecting the greatest number of people. By reducing the number of susceptibles in the community, it augments herd immunity, making the infection more difficult to spread. It also reduces the risk of those individuals who have escaped the vaccination or those who have not developed satisfactory protection. It is well to bear in mind that vaccinations are not all 100% effective, particularly when an individual is exposed to a large dose of pathogenic organisms. Vaccination has to be planned according to the needs of the situation. Every country has its own vaccination schedule. A well thought out immunization schedule must be epidemiologically relevant, immunologically effective, operationally feasible, and socially and culturally acceptable. We look at passive immunization. Three types of preparations are available for passive immunization: normal human immunoglobulin, specific hyperimmune human immunoglobulin, or antisera or antitoxins. Passive immunization is a short term expedient useful only when exposure to infection has just occurred or is imminent within the next few days. Duration of immunity induced is short and variable. Undesirable reactions may occur, especially if antisera is of non human origin. Passive immunization has a limited value in the mass control of disease. It is recommended for non immune persons under special circumstances. Sometimes we have to apply a combination of both passive and active immunization. Antibody in the form of immunoglobulins might be administered simultaneously with or around the same time as certain vaccines, for example, as post exposure prophylaxis for hepatitis B, rabies, and tetanus. The aim is to provide both immediate temporary passive immunity and slowly developing active immunity. Immune response to some live attenuated vaccines can be affected by receipt of immunoglobulin depending on the type of vaccine, amount of antibody, and timing of administration. Generally, immunoglobulin should not be given within 3 weeks before or until 2 weeks after administration of a live attenuated vaccine. However, there are exceptions to this rule. For example, the simultaneous administration of hepatitis B vaccine and hepatitis B immunoglobulin. Immune response to inactivated vaccines are generally not affected by antibody containing products. Inactivated vaccines can be administered before, after, or at the same time as the antibody products. However, the presence of circulating antibody to a vaccine antigen might reduce or eliminate immune response to that vaccine. The vaccine antigen should be administered at a site distant from the immune globulin injection point. Now we look at chemoprophylaxis, using drugs to prevent infection. Chemoprophylaxis implies the use of medication pre or post exposure to the pathogen to achieve protection or prevention of an infectious disease. Examples include HIV, where we use tenofovir and emtricitabine within 72 hours pre or post exposure for prevention. Also, in the case of bacterial meningitis, a single dose of oral ciprofloxacin or azithromycin or single doses of intramuscular ceftriaxone or twice daily rifampicin for 2 days to be commenced as early as possible, but not more than 14 days after exposure for all close contacts of a case. Also, chemoprophylaxis is applied in diphtheria, anthrax, tuberculosis, and malaria. We move over to non-specific measures. Most of the non-specific measures to interrupt pathways of transmission are of general applicability. A major obstacle to disease control is human behavior. Medical technology is often ineffective in changing behavior. In this regard, health education remains the only approach to enlist public cooperation and to induce relevant changes in the behavior and lifestyles of people. Such changes could in themselves be powerful methods of infectious disease control. Another important non-specific measure is community involvement in disease surveillance, disease control, and other public health activities and efforts. If community involvement is not an integral part of public health programs, they are unlikely to succeed. Laws, regulations, and policy measures alone will not bring the desired results. It is well worth considering some obstacles in the control of infectious diseases in rural and underserved communities. First and foremost, the scarcity of trained personnel, for example, epidemiologists, and poor public health awareness needed for the investigation and control of communicable diseases. A strategy which has been supported by the World Health Organization is integration of communicable disease control into primary health care. In this regard, all healthcare professionals should be technically equipped to a certain basic level.